Welcome to Case Cracking at Exercise Thought. My name is Sam Sook, and this is part of the specialisation training program homework, which all future specialist physiotherapists have to do. We're going to be talking about a case today that is a 25-year-old female social worker who came in with a combination of sciatic symptoms and hip stiffness. I have altered some of the details of this client case to make it easier to keep this person anonymous. And I hope you find it educational. Please ask questions, make comments, criticise my decision making, and be part of the discussion. So, 24, almost 25-year-old female with a few weeks of sciatic pain down the right lower leg and a generalised bilateral stiffness in both hips. She's described a stressful exam period recently, which meant that her lumbar and pelvis region just feels really tense. She describes it as muscular. And the symptoms down her leg she described as sciatica. And you always want to check when people say sciatica because it's not always the sciatic nerve. It's a very, catchy word for people to use. But she did describe true sciatica, which is posterior thigh and then into the posterior leg, sometimes going underneath the foot. Most often post-sitting, for example, after driving a car for a longer period of time than she normally does, or after sitting down for a long time and then getting up, she gets these posterior symptoms. That was one thing that we want to have a look at. And then the hip stiffness, she also described this feeling of impingement in through the hip. So that's something we also want to have a look at. So subjectively, these are the two things that are concerning for her. And then objectively, we started off with a hip screen. So that was, she was laying prone on the treatment table and I passively moved her hip into a couple of different positions. We found that the fadea was 20 degrees on the other leg and 30 degrees on the affected leg. No production of pain though, so negative on the fadea. We did a Faber as well, and we found that there was a decent amount of movement in the Faber, at least 45 degrees on both sides. So we're thinking if that's a decent amount of range. It's perfectly normal for someone her age to have that amount of range, and there was no production of symptoms. So the fact that the Faber and the fadea were really good makes me think that it's probably not going to be hip impingement. We also did a scour test. I took her up into passive hip knee flexion, and right to end of range, no pain. So really good signs here. So we're thinking less likely to be hip impingement, but there was some generalized muscle tension. If we just palpated through the muscles through her TFL, her glutes and lumbar, it's just generally tense. Not fearful tense, like, sometimes people will tense up when we take them through a particular range of movement, or they're anticipating some kind of pain or fearful of some kind of pain. That wasn't her. So unlikely to be hip impingement, and we're really a lot of reassurance to her that her hip structurally with the acetabulum and the femur is in really good condition. It's just a little bit of tension from the stress that she's had recently. Looking at the sciatic stuff, there's a couple of different ways that you can look at the sciatic nerve. We started with a slump test. So sitting on the bed, slumped her lumbar first, then it was cervical flexion, through in knee extension, dorsiflexion as well. And we found that this was positive. So a positive slump, meaning that it reproduced a very similar sciatic feeling to what she's been described. We also looked at a flexion in standing, so just standing, reaching towards the floor. And we found that that was also positive. Not positive in that it produced a pain, but it produced a significantly tighter right leg compared to the left side. So these are two asterisk signs from the objective that we wanted to have a look at. Again, her description of post-sitting getting this right posterior lower limb symptom makes me think that there's something to do with either a lumbar flexion posture, prolonged flexion then produces these symptoms, or it's just being physically inactive. So it's a lack of circulation. There's some kind of stagnation of fluid, It could be that there's some fluid gathered around a nerve that then refers symptoms down here, and once she gets up and moving, that fluid then moves around in the circulation and takes the pressure off the nerve. Or it could be that there's a lumbar disc that's pushing in on that nerve only after sustained flexion activities. You know, the disc is perfectly happy going for a walk when we're upright and extended. It's perfectly happy when she's laying down and there's no gravity pushing down. But when there's a combination of gravity and lumbar flexion, it seems like that. So these are our two theories at the moment. So to investigate that, as part of the, I suppose, further assessment but also treatment, we had a look at some Mackenzie stuff. So just propped up on her elbows, laying on her tummy, we found that that was perfectly comfortable, and we found that the slump and the flexion in standing were the same. So not impactful on her symptoms, still positive on both of those. So then we got her up onto an extended arm, so I suppose a higher degree of lumbar extension, and we started to see a reduction in symptoms. So her slump was previously a 3 to 4 out of 10 for that right posterior leg symptoms, and the flexion in standing was just significantly tighter on the right side compared to the left. After the Mackenzies with the straight arms, we brought that down to a 2 to 3, which I'm still not thrilled with. I want to see at least a 2% reduction to be convinced that the Mackenzie stuff's actually doing something. So we then progressed the Mackenzie further. She pressed all the way up and then breathed out, and that belly sag means that we get to drop into even more lumbar extension. And this particular lady actually said that she felt her lumbar was extending. She felt it was moving much more when she did the belly sag and the breathe out compared to the previous versions of the Mackenzie. After that, and 10 repetitions, so approximately 30 to 60 seconds worth of exercise, we were able to get her slump level down to 1, almost not there, in her words. The flexion in standing was the same as the other side. So doing repeated extensions reduced her symptoms, took pressure off the nerve, and improved both her asterisk signs. So we're thinking that this post-sitting feeling of sciatica is probably coming from prolonged flexion and is correctable with repeated extension. So the prescription, the homework, is that before she gets in the car for a long drive and after she's in the car for a long time, she's doing some kind of extension to balance things out. You know, I made a point of, I don't want her to be afraid of sitting because sitting's not dangerous for her. It's about a balance. So if we imagine a seesaw, if we do too much, this is flexion on this side, this is extension on this side. If we do a lot of flexion and we're really pushing the flexion side of the seesaw down, the risk of having a lumbar disc push on a nerve or a lumbar disc bulge become symptomatic is much higher. However, if for every amount of flexion, we're balancing it out with some level of extension, going for a walk, doing some Mackenzies, arching back like this, just standing up, even a hang can be a good way of getting some extension in. Then we can balance out those discs, we can take pressure off the nerves, and so that was my advice to her. We did also find that she was actually quite flexible with a FABA, and so the tension through her glute on the right-hand side, she reports, is partly because she's protective of that right hip because she's previously had right side hip injuries. She suspects that it's weaker on that right leg. Assessing the strength of that right hip compared to the left hip was beyond the scope of the first consult because we wanted to get on top of her symptoms, and we're making good progress into that. So I recommended catching up with her 4 days after the first consult to look at then hip strength. We're going to look at core strength as well. We're going to look at things like side plank, single leg bridge, resisted hip flexion. We've got a handheld dynamometer here, which we're going to use. So if you found this interesting, this case interesting, feel free to ask a question, throw a comment down. If you didn't find it interesting, fine, move on to the next video. And this is case cracking at Exercise Thought, and pleasure having you with us today.